Hello, everyone. My name is Karishma Lobo, and I'm the webinar manager for today's session. Welcome, and thank you for registering for our webinar. Uh, Today's topic is mental health economics, reflections, promises, and challenges. Today's webinar will run for approximately 60 minutes, and we will record and upload it on our website afterwards. Before we begin the webinar, I just wanted to run through a couple of housekeeping items. Today's webinar can be live translated and captioned in several languages. This is powered by an AI translation software named Wordly that provides real-time interpretation and transcription. However, please note that we have a limit of 50 people using this software at a time. As such, we request that you use the software if English is not your first language or if you have a hearing impairment. The link to the software can be found in the chat. If you experience any technical issues during the webinar, please add them to the chat box at the bottom of your screen and I will be happy to assist you. Everyone on the line has been muted with the exception of our speakers in an effort to eliminate background noise. If you have any questions during the webinar, please use the chat box. I will now pass it over to you, Harriet, to introduce our speaker for today.
Thank you, Karishma, and welcome to everyone. It's lovely to see so many of you, and I know that people have joined us from all over the world. So good afternoon, good morning, good evening, wherever you're from. So my name's Harith Al-Janabi. I'm based at the University of Birmingham, and I'm really pleased to chair this session, the first seminar for the IHEA Special Interest Group in Mental Health Economics. So the Special Interest Group in Mental Health Economics started around 2 years ago. It's a growing group with a growing range of activities. It was initiated by Pankaj Bencic at University of Chicago. And one of the nice things about this group is that it allows you to meet and network with quite a wide range of people across the world with a similar interest in mental health related economics. So if you are a member of IHEA, and I think many of you are, on this call, I'd really encourage you to go on the website if you're not already a member and join the Special Interest Group. So over to our speaker now. We've got Martin Knapp, and we're delighted to have him today. He's Professor of Health and Social Care Policy at the London School of Economics, also a professor at the Care Policy and Evaluation Centre, which some of you from the UK may remember as PSSRU. And he's director of the school, NIHR School for Social Care Research. He's got a fantastic sort of range of experience in this area. He's been making important contributions to health and care economics over the last 45 years, particularly in mental health economics and social care economics. And I recently found out, and this is possibly the most interesting fact for a speaker that I've introduced, that he's not only competed in the 1981 Barcelona marathon, but he actually won it as well. So that's possibly an achievement very few of us could ever achieve. So Martin, we're delighted to have you for our inaugural lecture, and please, you have the floor now. We're looking forward to hearing what you say. Thank you.
Thank you very much. I wish I could run anywhere near that distance and speed now, but there we go. Let me go to share screen. Okay, so hopefully that's visible. Can you see that? Yep. Okay, so that's a picture of English summer. That was taken weekend before last. I live in Kent. Torrential rain, beautiful rainbow. So we haven't quite got summer here yet. Anyway, I'm delighted to be here. I'm very, very honoured to have this. And I have to say, just a little bit anxious about talking to this group. There's a lot of people whose names I recognise from quickly skimming through the Zoom screens. And in particular, a lot of you are more expert on many of the things I'm going to talk about. So what I want to do is to zip through two sort of things, really. One is a little reflection back on mental health economics research, and then a little look, well, to the present or the future, perhaps, in terms of some of the challenges. As Harith said, I based at LSE full-time now in a research centre called CPEC, Care Policy and Evaluation Centre, formerly PSSRU. And most of the work we do is in the UK, or has been, but actually let's put this together from when I was talking to students actually earlier in the academic year. We do work across a number of other countries, not all in the mental health area, but pretty broad range of things now. And I saw a couple of people zipping through the Zoom screens that I'm collaborating with in some of these other countries. So what I'm going to focus on, although I'm going to focus on mental health, and a lot of the work we do and I do is in other areas, social care, for example. Going to focus on mental health, mainly drawing examples from high-income parts of the world, because that's where the evidence is, but I hopefully we'll be able to reflect on other parts of the world too. So what I'm going to do, first of all, is a little bit of what I've called ancient history, ancient in the context of mental health economics. The story I like to tell about this, when I first started working in this area, which was a long time ago, I used to have a copy of every paper that had ever been published in mental health economics. There are about 20 of them at the time when I started in the mid-80s, I suppose, in this topic area. And now there must be thousands and thousands, which is just an amazing growth in this topic area. Now on here, I've just captured front pages of 6 papers. There's some others I'm going to mention in a moment. One of them is a 2-pager from the Lancet in 1957. You wouldn't get that sort of thing published in the Lancet nowadays. But these are some of the papers, 3 in the US, 3 in the US, 3 in the UK, that were quite early contributions to looking at economic aspects of mental health. Now, what I'm going to do, I'm going to focus mainly on economic evaluation or costs and outcomes, but of course, many of us work across many different areas too, not just in relation to economic evaluation, but that's where I'm going to draw most of my examples from. And the other thing I'm going to do in terms of this sort of ancient history introduction, before I get into the reflections, is just to mention, this is a paper I wrote, goodness gracious me, all those, last century anyway, which was started off as a semi-jocular piece of work, but then became a bit more serious. It's not a historical treatise at all, but it's just reflecting back on my experience of working in the mental health area as an economist. And I think what I would say is that many countries have gone through these, at least the first 4 phases of reaction to economics coming into the mental health area. So firstly, I would say that there was just blissful ignorance, that mental health policy, mental health practice decisions were taken without paying any attention to economics. Then when people started to realize that economics might have something to contribute, I think there was often criticism and rejection, and certainly I got that. I remember people were saying to me, I've been told to speak to you because you're an economist, and I've been told I've got to bring you into my trial, but I don't really want you here. And maybe some of you still find that, but we've moved, I think, from that stage to then a phase I called undiscriminating utilization. People just they were desperate to include some economic information. That generally meant including a few cost measures, but they didn't quite understand what they were doing with the figures. This is the non-economists. And then I think we've reached this stage, broadly speaking, of stage 4, constructive development. People have a mature, well-rounded, good appreciation of what economics can and can't do. And then stage 5, their sublime sophistication, just a bit jokey. I'm not sure we'll ever get to that. But I do think we've moved through this phase, and I think economists now are widely and appropriately accepted into the mental health area as people who can make good contributions to research and to policy discussion. So I'm going to say, I've said then and now, and I've got 1, 2, 3, 4, 7, whatever it is, little sections here. I've got one slide, I think, per section, or 1 or 2. Just want to reflect back and see how far we've come. Now, some of these changes over time are mirrored in what we see in other parts of economics, particularly other parts of health economics. And they're also, some of them, mirrored by what we see in other parts of, or see in the mental health field more generally, not the economics area. But I think the mix of economics and mental health raises particular challenges, and to some extent particular opportunities, and I want to just highlight those. And then the final one of those, challenges of implementation, that's going to be the main section I'll have at the second part of the presentation. So firstly, in relation to mental illness, and we'll all be familiar with these kinds of pictures. These are pictures of institutions from the distant past. The one on the top left is a painting by Hogarth, who spent some time in psychiatric asylum in London, the Bethlehem, as it became. And the picture on the right is taken in 1900 in a workhouse in London and so on. So these are old pictures. We all recognize these. That's mental illness then. And this is mental illness now. This is Venezuela 2 years ago. So these old asylums, these horrible, horrible places are still existing, I'm afraid, in some parts of the world. And there are many other examples that I could give. So in some respects, we haven't come very far in relation to mental health practice and policy. In some other respects, as we'll see as we go through, we have. So a few things then about mental illness itself. I mean, it was first included in the International Classification of Diseases in 1949, so much later than other non-mental health illnesses, if you like. And there's been lots of refinement over time. And so I think economics research has kind of mirrored that, where our research has got more sophisticated in looking at new areas. Social anxiety, PTSD has been more thoroughly understood, shall we say. But also, I think we've seen this trend to a different approach, two different approaches, perhaps, which come together. One is this, what I would call general psychopathology, the P factor, and the little chart on the right-hand side, if you can see it, comes from a paper in Journal of Child Psychology and Psychiatry, which is, it's saying that, okay, there are these diagnostic groups, there are these different conditions that we should be aware of, but it's probably also a general psychopathological state that people have. And that may well be very important in driving what experiences they have. And in research we're doing now, we're finding this P factor to be pretty important in understanding some of the cost variations over actually a 20-year period. So that's one change. We've moved away from, or recognizing the need to move away from some of the previous diagnostic approaches. And the second is the staging approach. And I think I spotted Crick Lund in the meeting here. And Crick is an author of something I'm going to show in a moment, which is a very good Lancet Commission on Global Mental Health, which has got a very nice account of the staging approach. It's, I think, attributed to Pat McGorry initially. But let me come on to that. And before I do that, just to mention that what these changes have meant, I think the reason why we're seeing, I think, some welcome changes in the way that mental illness is portrayed is that it does, that the conventional diagnostic categories don't work very well. In this country, in the UK, or in England, we had tremendous problem developing DRGs for mental health problems because there was so much variance around the cost measures. So I think sometimes the diagnostic categories we've got are helpful for some purposes, but not for others. Now, this staging approach, this is then a little picture taken from that Lancet Commission I mentioned. The staging approach is then talking about perhaps a more fluid look at how mental health problems change over time. So in this particular diagram, you'll see down the bottom there, 3 syndromes. Yes, there are different areas of mental illness, if you like, anxiety, mood, psychosis are the 3 syndromes identified here. But then particularly in young people, attaching precise diagnostic labels to the experiences that they are having and they are displaying doesn't necessarily make sense. There's much more fluidity, much more flexibility that we need to bring into our research. So the first theme then is mental illness. I think the way that mental illness is conceptualized and understood and analyzed has changed, and economics needs to change with it. The second is involvement. And again, you've got a range of pictures here. On the right-hand side, again, these are things you'll all be familiar with. People buried in the old asylums, but without a name. You know, if we couldn't be bothered to put a name on a gravestone, then we weren't going to be bothered to involve them in research. So we've come a long way from just burying people without a name through, you know, the atrocities in the Nazi era, the atrocities in the Soviet era. We've moved a long way from that to involving people now as partners, as you know, co-producers of the research that we undertake. That's a huge change, and it's made research more complicated in some respects, made research much more satisfying in other respects. But I think 2 things to say towards the bottom of that slide. Firstly, I think sometimes we forget that people with lived experience of mental health problems and people who do research on mental health problems are not mutually exclusive groups. And there are lots of people probably on this call who've had lived experience of mental illness. And secondly, co-production. If we're going to do it properly, Co-production then challenges our approaches sometimes to designs and the measures that we use. And people with that lived experience may not like the measures that we think are the beautiful things to include in our studies. So that co-production thing can be a challenge. Third, then and now, is around evidence and how evidence is assembled and used. And, you know, I'm going to try not to indulge in too many reflections back to when I started as a researcher. I started as a researcher in 1975. I was only 3 years old. I was child prodigy. But I mean, at that time, you'd wander around the library. That's where you got your references from. There was no electronic databases, of course. And over time, of course, we've got much better at systematically understanding what is out there already in the literature and how we might go forward in using that previous work to contextualize what we do. And we get these, you know, now we into these very sophisticated network meta-analyses and other things, which I can't do, which give us a much better way of picking through the existing literature. And I think that's helped to give transparency to the research and avoid some of the publication bias. And again, you can look back at some of the mental health research, the economics research, and on, for example, the second generation of antipsychotics, on the SSRIs and so on. It was very biased in terms of what got published and what didn't. You wouldn't get away with that nowadays. Okay, now the next little then and now is on perspective. I mentioned 6 papers. I showed a screenshot of front pages of 6 papers at the beginning, and one of them is this. It's a paper by Bert Weisbrod from the University of Chicago, and it's a classic. To me, I've called it a jewel on the slide. I love it as a paper. It was a randomized controlled trial of what we would probably call assertive outreach, people who were not engaging with services, community services, going out, finding them, getting them back into contact with services, making sure they're okay. And Bert Weisbrod, who hadn't worked in mental health before, was a very strong economist in other areas, came and did the economic evaluation. And it's a fabulous study. I mean, it's a fabulous study for the breadth and range of costs that were measured. And on the left, when I was trying to find a copy of this paper, I've got a copy in my office, but I haven't been there for 15 months. But as I haven't got that copy. So I went onto the web and I found this one, and it's a PDF of somebody's personal copy, and they've written all over it. And it's wonderful to see what they've written. You can go and find it on the web yourself if you want to. But what Bert Weisbrod included was a whole range of costs, not just the health service costs that most people include, but all those other things on the slide there, looking at a whole range of things in criminal justice, in terms of personal expenditure, family burden, and so on. Very, very unusual, even today, to find that breadth of cost measurement. The benefit side, there was the trial itself had all sorts of clinical measures as clinical endpoints as measures, but the economic evaluation was he was trying to cast it into a cost benefit framework. So what we've seen, I think, initially, I would say that some of the initial work on cost of illness in mental illness is pretty good in terms of perspective and trying to cover not just the health service costs, but the societal costs. We don't always see that nowadays. I think probably studies are too narrow in their perspective sometimes. But what we have seen importantly, and down the bottom of the slide there, this important emphasis on carer or caregiver costs and outcomes. I know a number of people on the call today have done a lot of work in that area. So that's a big change. And that's where I think in the mental health area, the impacts on family and other carers are especially large, much larger than we would see in many other health areas. So that's a perspective. I mentioned endpoints a little bit already, just to say some reflection about how things have changed. And I've just marked a sort of journey. It may not be quite a linear journey from the top of the slide to the bottom of the slide, but early research, early economics research you can find, and mental health research more generally, was focused on destinational outcomes to people, where people admitted into hospital, when they were discharged, how long they were there, what were the mortality rates, and so on. Those sorts of things. Maybe a relapse rate might be, I could have put that in there as well. Sort of destinational outcomes in that sense. And then we moved through physician assessed, through to observer or interviewer assessed, through eventually to PROMs, to patient or user or individual rated outcome measures using either structured questionnaires or sometimes less structured, a mix of qualitative and quantitative methods to get these endpoint measures. And somewhere along the line, QALYs came in, initially the generic ones, then the condition-specific ones, and then we're now seeing much more exploration of these well-being or happiness, these higher order subjective outcome measures. So I think, again, in the mental health area, I would say this is a very, very welcome development. I was one of those people I was highly skeptical about the QALY, particularly EQ5D, whether it was going to work in the mental health area. And in some of the studies that we did in my team going back 25 years or so, we didn't include the EQ5D because we didn't think it worked. I don't have that view now. It does work, I think, across many areas of mental illness, but I'm pleased to see we've got exploration of condition-specific and these higher level measures. Then on to design and data analysis. And I put two long quotes in there, and I'm not going to have time to read them. I don't want to read them. But the one on the right, I quite like. It took me a while to find it again. I could remember it. It's from a paper from, I think, 1999, from a group at RAND. And what they were comparing was the sample size you need within a randomized controlled design to get sufficient power to test differences in different things. They say a sample size of well under 100 might be fine for many changes in health-related quality of life, many changes in clinical measures. Maybe you need, once you get to looking at cost variations, particularly in the mental health area, you probably need sample sizes in the thousands because of, as we know, the very high variance, particularly high skew in cost measures in most mental health studies. So the design issue then, again, there's a particular challenge, I think, that characterizes mental health research, which perhaps is not seen quite so often elsewhere. I couldn't avoid putting this in again. This is my second and perhaps final indulgence of the day. But when I started doing work in this area, you did your regression analysis on punch cards. You cycled to the computer center, you put your cards in. At the end of the day, you went back and got your printout. And if there was one tiny error in your punch card, then your regression equation had failed. And you went back the next day and did it again. So it took a whole day to produce relatively straightforward regression equations. Now we've got much better chance to explore our data. And I think that the emergence of big data sets are especially, again, important in the mental health context because of the degree of heterogeneity in individual circumstances and outcome achievements. Okay, so I just wanted, those are just reflections, and I apologize for the indulgences, but let me then go on to what I call some challenges of implementation. And I think there are 8 I'm going to say something about, and they're challenges of how do we move from the evidence that we're generating. In this case, it may be evidence through cost effectiveness or similar analyses, similar studies. How do we move from that evidence to have an impact on practice, have an impact on policy? So this is not an implementation science slot, but clearly implementation science is one of those new areas that's emerged, can be enormously helpful. I think probably it ought to become a probably compulsory course in health economics programs, maybe, because I think there's a lot that we could gain. What I'm going to say, there's a paper I wrote with Gloria Wong in World Psychiatry last year, where we started to explore these, but I've added a couple more challenges over the last few months or so. So let me pick up on those one by one. So the first one is the problem of the evidence gap. And I mentioned earlier my little box file I used to keep of photocopies of papers I could find in the mental health economics area, the 20 or 25 of them that were around when I started working in the field. And now, of course, we've got thousands of them, but there's still huge gaps in our evidence base, very particularly in lower middle income countries. There's still very, very few economic evaluations outside the high income parts of the world. And I'll come back later on to high income settings as well. So there is that gap. So that's the first thing. And the second thing is this point about economic evidence not generalizing, not translating very well from one context to another. There used to be a little expression in England about beer. Beer doesn't travel well. Beer, in the old traditional sense, breweries were always local, because if you tried to transport beer from one village or town to another, the quality deteriorated markedly. So beer didn't travel well. Economic evidence doesn't travel well either. So we have to think about how we can transfer. And it's more complicated, I think, with the economic evidence than it is for the clinical evidence. So what's the response there? Well, we need more and better research, of course. We need to replicate studies which show some perhaps important findings, try them out in other contexts. We've got all the synthesis of the evidence. I mentioned network meta-analysis and so on, which is one way to synthesize the evidence. We're seeing adaptation in terms of the services. So this works in, I mentioned the Burt Weiss study. It worked in Wisconsin. People then adapted it. And I'm aware of adaptations in Melbourne, in London, and one or two other places. If that was then taken to a low-income or middle-income country, the adaptation would have to be much, much greater. And then that leads to these explorations of task-shifting models. And I put always include economics. I still find it astounding, really, that people can do clinical trials and not include an economics component. I just don't understand why you wouldn't want to do it, given how little the cost is to do that. It might be difficult to find the economists. That's maybe the only justification, but I would always want to see that. So that's the first challenge. We don't have the evidence. We need to find development ways, adaptation ways. The second challenge is what I call worth it but unaffordable. So we do our beautiful economic evaluation, find that something is cost effective. Yes, it's effective, it's great, but unfortunately it costs more than what we are doing previously. But by some reference point, come back to that in a moment, we think it is cost effective. It seems worth it to do it. The outcomes justify the higher costs. But then the challenge is there isn't enough money to pay for that. And in the bottom of the slide, bottom right-hand corner, there's a handwritten letter that I've just taken a copy of. So in our government in the UK, we have a very senior minister called the Chief Secretary to the Treasury. So he or she is the second most important person in the finance part of government. And we had a change of government a few years ago, and the outgoing Chief Secretary wrote a little note and left it on his desk for the incoming Chief Secretary. And it said, "Dear Chief Secretary, I'm afraid there is no money," and then signed his name. And unfortunately for him, that letter went viral. But sometimes governments don't have money. So what do we do? It's worth it, but the intervention is unaffordable. Well, what do we do as economists? We would normally think about what are the what's the incremental cost effectiveness ratio? How does that compare with willingness to pay thresholds, health technology assessment thresholds, and so on? We do those sorts of things. But I think what we have to remember throughout is this is a value judgment. At the end of the day, we're moving from all the scientific stuff, all the robust stuff that goes into the evaluation, now to a value judgment, a subjective value judgment that somebody thinks that society is going to value this outcome sufficiently to pay for it. And mental health, we know over the centuries, has been open to bias and prejudice and discrimination. And I worry sometimes that the value judgments that decision makers may bring to these decisions may also be open to bias and prejudice and discrimination and so on. So mental health, I worry about sometimes in these contexts, mental health interventions. Third challenge is about real savings. This is not a mental health specific issue. But we know in our research studies, we talk about how this intervention will reduce length of stay in hospital or reduce the rate of admission into hospital, and that will lead to all these savings. And we put that into our papers. But of course, those savings never arise unless you close the hospital or you close the ward of the hospital or you move staff out. Those are not real savings in the short term. Yes, it could mean that new patients can go into the hospital and get treatment, so that improves the health of the population. But in terms of savings, money savings, we don't get that immediately. So that's a challenge I think we often face, and it's a particular challenge. I mean, I started my work in this area looking at closure of psychiatric hospitals, and this was a big issue. It took 8-9 years to close a psychiatric hospital from the date of announcement. So if you're looking for savings, those savings are going to come through very slowly over that closure period. So the responses, well, there's lots of them. I've just put a plug for a report that we did for the United Nations, published last week, on how COVID might have crystallized the case for deinstitutionalization. We were asked to look at all need groups, all age groups, and all countries. So it's quite a challenging piece of work. But you can see the same issues arising across the world today in barriers to closing institutions, a lot of them to do with the financial economic barriers. fourth challenge, which I think again is particularly acute in the mental health area, is the familiar one that we all have of silos, where the costs or the cost consequences, say, of a particular condition, or the costs of intervention to respond to that condition, those costs are spread across many different budgets, many different agencies. And mental illness is particularly characterized by this. I showed you that slide earlier from Bert Weisbrod and his very good study from 1980. I mean, he looked at health and social care and homelessness and criminal justice and family and so on. That's just an example of some of those silos, separate budgets, and then that creates all sorts of disincentive issues. The little pie chart there is from a study in England quite a number of years ago now, which showed that 90% of the cost of depression was associated with workplace issues, lost productivity because of absenteeism or presenteeism. No, they didn't even measure presenteeism. It's only absenteeism or non-work, and another percentage of the cost was due to premature death. So there are high costs of associated mental health, which are outside the healthcare system. And so we have to keep reminding people of a number of things. One is that mental health is not just a healthcare issue, it's a whole of government issue or a whole of society issue, and policy needs to reflect that. But secondly, we have to think of ways of how the winners can compensate the losers. How do we work with that? An example I've just put on the slide, we have this thing called IAPT, Improving Access to Psychological Therapies, which many people describe as a revolution in delivering psychological therapies to people in this country. It certainly speeds up access in our system, which was very, very slow. And I was involved in doing the economic evaluation work that led to the discussions between government departments. And when IAPT came in, there was an explicit discussion that the Department for Work and Pensions, which would pay the welfare benefits and so on, would compensate the Department for Health that was going to pay for this psychological therapy program. So you need to have these discussions to break down these barriers between the different silos. Next challenge is how long do we have to wait? There are often very delayed payoffs in the consequences that flow from mental health interventions. We've all, I'm sure many of us have done studies which have shown, for example, the links between childhood or adolescent mental health problems and adulthood consequences, or the consequences of an intervention in the mental health area, which are perhaps quite impressive in the first couple of years, but in many cases can last for much, much longer. So there are often very long payoffs, very long-term payoffs, but sometimes the payoff may not be very big in the short term, and we have to wait. And I've coined a term, it's not my term, I heard it from a civil servant who couldn't tell me where he got it from, a term of diagonal accounting. We need to think about this double disincentive, that why should I spend money from my budget when the savings will come to your budget? And secondly, why should I spend money from my budget when the savings come to your budget, but 5 years or 10 years down the track? So this double disincentive, this double barrier to investment in what might be very effective interventions. And well, here's an example, just a piece of work that we did looking at the long-term mental health consequences of bullying. We looked at a cohort data set which looked at bullying in ages 7 to 11 for children reported by parents, by teachers, and looked to see, firstly, what the chances were that they would be using mental health services as they went on. These are odds ratios, and the sort of zero line, if you like, or the reference point here is never being bullied. And these are, you can see, quite high odds ratios of using mental health services. And then in the second paper, we looked at what are the cost consequences, cost to the individual, cost to the system or to society, and more than 40 years after the bullying, there are significant differences between the frequently bullied group and the rest of the cohort in terms of service use, productivity losses, and the other things you can read on the slide. So long-term consequences, which then require long-term planning, and then the sort of impact in terms of decision-making is we need our policymakers to be patient, I'm afraid, but they need to invest for the long term. The next challenge is transmission. Again, this is, I think, a particular challenge in the mental health area. It's not exclusive to mental health, of course, but I think very often we will see a mental health problem experienced by one person having spillover, external, other effects on other people, particularly other family members. So, the picture at the top is of family carers. We know that people who are caring for somebody with a mental health problem or a neurodevelopmental condition like dementia are incredibly stressed and have their own mental health problems quite often. And we know, the picture at the bottom, that there's quite a high transmission of problems from mothers with mental health problems during the perinatal period to their children. And this slide just gives you some results from a study that we did, led by Annette Bauer some years ago now, looking at the economic manifestation of those experiences. So we're looking at postnatal depression in women and the consequences for their child, for the birth child. And we know that those birth children have a much higher risk of emotional problems, of behavioral problems, and cognitive problems as they grow up because of their mother having postnatal depression. And we then costed those in terms of higher service use, productivity losses, and then we attached a monetary value to the quality of life impacts. So this is a very good example of this transmission, and therefore we need, services that then either prevent or respond very quickly to these needs as they emerge. Challenge 7. Does it work for everyone? And nothing works for everyone. I really like this little paper. It's not a very long paper in Nature from a few years ago now. And what this author did was to look at, in the left-hand side of the slide, in the graphic, the 10 biggest grossing medications in the US at the time. The one in the top left is Abilify, aripiprazole for schizophrenia. The others, I think, mostly, there's duloxetine for depression. The others are non-mental health medications. And what he did was to say, calculate for every person they do help, that's in blue, how many people fail to see gains in their health, improvements in their health when taking these medications, based upon number needed to treat type analyses. So you can see, there's a huge, the aripiprazole, 1 in 5 people who take it seem to have the clinical response that is expected of that kind of intervention. So we've got what he called imprecision medicine. And it applies not just to medications, but to a whole range of other things. And so I think the challenge then is of two kinds. One is, I'm going to come on to the precision medicine in a moment, but one of them is around personalization. We have to think about the individual with the mental health experience, the context in which they live, their family and other support, if they've got it, and so on, and put that person at the center of our decisions about treatment and care, and understand what's important to them. How do we respond to their needs and their preferences and their strengths? Give them the opportunity to make choices and so on. And that's linked to many things, including, as we know, this sort of recovery approach to mental illness, which has been around for a long time now, and to things like person-centered care. And we did an evaluation 15 or more years ago now, quite a few years ago, of personal budgets, where people would be given the budget to hold themselves. This is in the social care system. And in the evaluation we did, it was the people with mental health problems compared to those with disabilities or age-related needs. It was the people with mental health problems that gained the most in terms of improved well-being, improved satisfaction, and so on. So giving people that freedom to some extent to choose how they are supported can have huge impacts on their well-being. And it was cost-effective in that sense as well. And then the other is around this precision medicine. Can we identify genetic and other characteristics of individuals, which mean we can target our treatments? And that's then opening up a whole new area of economics research. I started to do not some research on it, but to look at the literature 2 or 3 years ago. And I had not realized how big the literature is in the cancer area, the economics literature, really quite impressive stuff. So I think in mental health, we're not got that literature yet, but that's clearly something that's going to be coming along quite soon. Okay, and then the final challenge is around fairness. It's a follow-on from that previous one, that people come into the mental health system, if you like, with a of course, huge variety of characteristics and circumstances and preferences and so on. And what they will experience in the system is also very, very different. But I think too often in our research, well, too often in my research anyway, I'm sure you're all different from me, but in my research, we talk about the variations and we show our standard deviations and so on, and we do our regression equations to show which factors seem to be associated with higher or lower costs or better or worse outcomes. But we don't really go the full distance in trying to then tease out what the consequences should be for policy and practice in targeting those groups. And as I put on the slide there, I think costs are often highest and cost effectiveness often lowest for the most disadvantaged subgroups within our populations. And those are also the people who often have the worst access to the interventions that we know work. So I think there's an enormous challenge for everybody working in this area, not just economists, but everybody, to do better. I mean, not just saying there are inequalities, but actually how do we then address those inequalities? And this is just a graphic from Public Health England, which just highlights this, some of the evidence on this. I'm not going to keep this on the screen for long. Okay, I think I have pretty much finished. Just want to say in relation to this one, I think we just need to be more assiduous in including equity analyses when we're doing our work. Okay, so I hope my views are entirely my own. I may have plagiarized some along the way, but I'm not claiming that they belong to my employer or any of my funding bodies. So with that, Harith, I have finished. Thank you very much.
Thank you so much, Martin. Do you want to stop sharing? Thanks. Yeah, thank you. You packed an awful lot into 35 minutes there. So thank you so much. Very interesting stuff there. I've asked the audience to sort of register their questions in the chat. So please do now put either if you want to ask a question, or you could put the actual question you want to ask in the chat, and I will ask you to read it out to Martin. So we've got a question from Rui Martins to kick us off. Rui, do you want to unmute yourself and ask Martin your question?
Hello, can you hear me okay? First of all, I want to thank for the really interesting presentation. And so my question is related to disease severity and how to accommodate for disease severity in cost effectiveness analysis. So diseases like schizophrenia are considered very severe and are often associated with externalities. Most of the resulting costs often fall outside the healthcare sector and involve macroeconomics. Do you see a way forward in standardizing the incorporation of this economic burden into health cost effectiveness analysis and economic evaluation? It comes to mind the utilization of quality modifiers according to disease severity, but I would be really interested in your take on this one. Thank you.
Thank you, Rui. That's a very good question. Firstly, I think it does talk to this issue about silos, and I think some of those, when people get to very severe levels of their mental illness, the consequences outside the health sector are probably bigger and bigger. Whether that's you take schizophrenia, whether it's in terms of dangerous behavior for the individual, themselves or to others, perhaps engagement in socially inappropriate activities, homelessness, a whole range of things which then spill out. Those are outside the healthcare sector. I think the challenge therefore is we need to, as researchers, we absolutely must include those. Maybe we can report for some purposes the healthcare only costs and the healthcare focused outcomes. But I think we need to be really impressing on our funding bodies that we need to find a way of collecting those data. Even if we can't collect all of them, let's at least try and get a good picture of that. In terms of the outcome side, yes, I think there's a challenge. again, I said at the beginning, there are people on this call that are much more expert in different areas than I am, and I'm not an expert on how we might use different weights within our QALYs and other type indicators. But I do think that we need to be making sure that the measures we use on the outcome side as well as on the cost side are appropriate for the circumstance. And it may be that somebody who's going through a very florid phase of their schizophrenia, I mean, the outcome domains in some respects could be very different from somebody who's sort of got basically sort of burnt out psychosis, but they still have some support needs. So I think we just need to be, again, it goes back to this point about the staging of mental illness. I think the diagnostic labels are perhaps too crude to pick up the variety that people experience within those label categories.
Thanks, Rui, and thanks, Martin, for your response. Just while people are thinking about questions, please do put them in the chat or register your interest in the chat. Maybe I could ask a quick question to you, Martin, which was, I suppose, thinking about the world post-COVID, a lot of healthcare budgets are going to be under pressure, and decision makers thinking about making disinvestment decisions with healthcare budgets. And I'm always worried that areas like social care and mental health are an easier target for disinvestment in terms of diluting or deterring people from using some of those services. And I wonder if you had any thoughts about what economics can contribute to understanding how mental health investments might be protected from disinvestment, or at least informing where we should avoid cutting or reducing services.
Yeah, I mean, three things quickly come to mind. I think one is, I think we have a good understanding now, and I think probably increasing understanding of the comorbidities that often characterize the lives of people who have mental health problems. And we know from, it's not a lot of research, but there is some, we know that, for example, somebody with diabetes and depression, if you can help them to manage their depression better, then they themselves will manage their diabetes better. If you can, I mean, the old story you'd have, somebody who's a cancer patient who would say, "Doctor, I'm feeling really down," and the doctor's response would be, "Well, I'm not surprised, you got cancer." Whereas, I mean, they wouldn't say it quite that callous way, but now I hope the response would be, actually, we can help to treat that. And if you can treat somebody's comorbid mental illness when maybe their primary clinical label is something else, then you're certainly going to improve their quality of life, but you probably improve, as I say, their management and their other condition. So I think firstly, it's trying to see mental health as not separate from other morbidities and the responses to those morbidities in treatment. Secondly, I think that on the prevention side, I think there's lots of evidence now that the preventive activities in the mental health area are highly cost effective. There are lots of things we know that are not high cost, are not complicated. They just need to be done outside the healthcare sector in the main, but there are things that we can do. And I would really hope that by changing some of those things that happen in workplaces, in schools, in primary care clinics and so on, we can do in emergency rooms, with lots of things we know we can do, which don't require major changes in practice, but can have quite an enormous preventive benefit, which is then very, very cost effective. And then the other thing I would just say is, which is, I think, is that the more we can get people to share their experience of mental illness, the better that will be. And I showed you a slide from the perinatal mental illness work we did, which was funded through a charity, just looking at the costs. And when we reported this, the charity organised a room in our parliament in London, not a parliamentary session, but just a reception there. And they got the minister responsible for mental health to come along, and he said a few words. He was great. He was very supportive. And then it was due to be after him. It was supposed to be me saying something. And before I could speak, another minister stood up and grabbed the microphone. And this was a very senior minister, Andrea Leadsom, if you know, if you're UK, who was then Chief Secretary to the Treasury. And she said, "I want to say a few words." And she talked about her own experience with postnatal depression. Now, the consequence of that study was there was a big injection of money into maternal mental health services, which we think was not unrelated to what we did. Other things happened as well. But I think sometimes you need that personal testimony, and we need more people to do that and stand up to talk about their own mental illness. And I still think there's a stigma about that, and politicians particularly are worried about how they might be seen. But we need more and more people to do that if we can.
Thank you,
Sorry,
Martin.
long answer.
Yeah, no, long answer, but very, very informative. Michelle Evans had a comment following on from that question. Do you want to ask Martin or make the point out loud?
Hi, good morning. It's 1:20 in the morning here in Australia. So thank you for keeping me awake at this hour of the night. So I work in one of the mental health areas in one of our LHNs, and the two issues are simply the staggering increase in demand, and particularly in spaces that we didn't expect to see this increase in demand from a COVID perspective. And one of them is in the, in eating disorders and pediatric eating disorders, and it's just burgeoning. The demand is just phenomenal. So, I have a budget of about $70 million for mental health in my space. And there's been no thought about having that reduced, but it's just not enough. And coming on from that, of course, it's not that even if the money is there, we have such a limited amount of qualified professionals to actually then be providing that care.
Yeah, I think this is exactly the point. I think Harith's point was, we're all going to be under pressure. Are we going to lose the budgets? But we're also seeing, the evidence that I haven't contributed any myself, but the evidence I've seen from other people about the mental health consequences of the pandemic, is clearly very, very clear in terms of, exacerbating the experience, the negative experiences of people with pre-existing mental health problems, but also then a lot of new people because of the anxiety, because of the lockdown, social isolation, and so on, developing new mental health problems. And now we've got this, this growing understanding of what long COVID might mean, the post-viral syndrome, and so on, which I think is probably going to have, again, a range of mental health components to it. Those are going to put enormous pressures on the system. But the one thing that it's kind of slightly, just following on from your comment would be, we know with some other post-viral conditions that sometimes it's argued that some mental health interventions can help people, without suggesting that the syndrome is psychiatric in nature, if you like, but sometimes some psychological interventions can work. But then you get a big pushback, and it'd be interesting to see what happens with long COVID as to whether mental health interventions are being recommended to help people address the post-viral experiences.
Thank you for the question and response. We've got a question from Anna Pomahak.
Thank you. Hi, Martin. Thank you very much, firstly, for that excellent presentation, and the fact that you had to pack in so many points and issues kind of self-explains how complicated mental health management is. And yeah, it's a huge task. And I think unless each and every one of us get involved, it cannot be really managed. However, regarding a very specific issue, we are always talking about cost effectiveness or effectiveness of an intervention. And it's often more inclined towards investment of money into a particular chemical solution being offered to most of the patients, and then how many of the patients get improved or not. However, the problem, the underlying cause, is often not a chemical problem in the brain. For example, I can share my own personal experience. Suddenly, I was in a new country with very little money, and that financial stress was causing me extreme amount of stress and depression. However, I was offered counseling with the point, oh, don't feel bad about it. Didn't solve my problem. After my child was born, my body was so broken that every second I had a fear of dying. And I was offered an antidepressant. When my child was diagnosed with a disease which did not have any cure in the whole world, and I couldn't find anything, being a doctor myself, instead of information or reassurance, I was offered, the antidepressants and things like that. So looking at those realities, is there any study actually looking at people with mental health issues, maybe in a community, helping each other with these alternatives to chemical solutions versus treating patients living alone at home, which is infinitely more expensive? Thank you.
Yes, that's a really good point. I mean, I think there are two things I'd say to that. One is I think that as a society, as a community of researchers, we're getting a better understanding of what are the triggers for mental health problems and traumatic experiences of various kinds, whether it's, forced migration in some cases, or traumatic birth and so on, a whole range of things. We're beginning to get a better understanding of those. So I think that's the first thing. Secondly, I think then the challenge sometimes is that the interventions that we have available are not easily adapted or need to be adapted to different cultural contexts. So if then the intervention is going to be a psychological intervention, it needs to be culturally appropriate to the circumstances of the individual and their own culture and upbringing and a whole range of other things, and that makes it more challenging, I think. So the chemical solution, works fairly well. It transfers fairly well across countries, fairly well. But the other interventions, I think, need to be much more nuanced in terms of how they're developed. That then raises the issue about how complicated and expensive and cost effective it is to do those adaptations and so on. So I think you just raised this issue of translation of evidence across countries as an important challenge. Thank you.
Is there any study looking at that?
Well, I think there are studies of. I mean, there's a guy called Bryn Lloyd Evans at University College London who's very interested in social capital, social prescribing, and so on in the mental health area, trying to then bring together the strengths of communities and community actions. I mean, there are lots of other people working on it, but he's one who comes to mind immediately. So I think it might be then thinking about what can people gain, and if of course they've moved from one country to another and are isolated away from the communities in which they grew up, that makes it much more challenging. But we do need to, I agree, that's an important approach to take.
Thank you very much.
Thanks, Annapurna. Thanks, Martin. I think we've got time for possibly two more questions. So we've got one from Carl Theodore. Carl, do you want to ask Martin your question? Carl, you're just on mute at the moment. Thanks.
Yeah. I basically, first I want to really thank Martin for what I call a very enlightening presentation. But I was struck by a couple of points you made. One in particular. Well, I am from what I call one of the lower middle income countries, and the point about the resource allocation bias against mental health is very significant. Somehow policymakers, they don't seem to think that mental health is an area where they're supposed to put their resources. Now, what we are doing at the center I work for, it's a health economics research center. We are trying to focus on the sort of economic cost of mental health, hoping that would somehow drive the message home to them that they have to put in some resources. They have to invest in trying to deal with this thing. I don't know if you had any other suggestions, or if you had any idea. How do you get a set of policymakers who don't really seem to think that mental health is an area that where they would give a high priority for investments at all? How do you convince them that this is an area that they're supposed to do something? I don't know what your thinking is.
I mean, I said some things earlier. I think the cost side is clearly one. I mean, in the work we've done and we're continuing to do in the perinatal mental illness area. So Annette Bauer is leading the project we're doing now in some other countries. And we had a very interesting dialogue with a group of people in South Africa, online meeting about 2 months ago, 3 months ago, where we were talking about, what the big cost would be of maternal mental health problems. And the response back was really quite enlightening. The response back was, that won't make any difference.
You are breaking up. I'm not.
Yeah, policymakers here, are getting, there's a queue of people outside the door saying, look how expensive this is, look how expensive that is, look how costly that is. And what they need is, so I think the message on the overall cost can work, but I also think what the policymakers need is, this is not just expensive. Okay, this is not just expensive, but this is also needed. We can do something which is hopefully cost effective. I'm not sure whether you heard all that, but.
Yeah, I think Carl's line might have been breaking up, but we heard you clearly, Martin. Thanks very much. There's one final question from Amawani, perhaps, and then we'll draw the session to a close. Amawani, would you like to ask Martin your question?
No, I don't have a question, but perhaps just a comment that often one area that might be neglected in research is look at the income tax consequences or tax revenue consequences of improving the productivity of patients who might have mental health issues. If they could become more becoming more productive and earn $100 more, and the marginal tax rate was 25%, the governments could collect an additional 25% and fund mental health in that way. Just a thought.
Yeah, I think in our economic evaluations, we normally say, but that's a transfer payment. We don't include that in some of our calculations. But I agree, from a government sector perspective, this is why I think having multiple perspectives in evaluations is really important. So you're looking at the government as a perspective, that would be important in that consideration. I mean, I did a paper quite a few years ago now with a couple of people at WHO in the mental health area, looking at what the economic benefits would be of investing in mental health in particularly lower middle income countries. It was just a literature review type study. But I think when you start to think of those wider macroeconomic consequences, then the case for mental illness action, I think, looks much more attractive, much greater. Thank you.
Great. Okay, I think thank you so much, Martin. Thank you everyone for your questions. I think we'll let Martin go. I think it was your 4th talk in 3 days, so it's been a bit of a marathon, if you pardon the reference to your running career earlier on. You've covered so much interesting terrain, and it's been a fantastic sort of introduction, I think, to some of the challenges in mental health economics, and something hopefully we can build on in our further discussions. And it's been great having the involvement of the audience as well. So I just remind you, if you are interested in joining the special interest group, to register your interest in the iHear website. And I think Panka's also included a link on the chat. But maybe we can just all thank Martin virtually for his time and effort with the slides and presentation, and look forward to speaking with many of you about mental health economics in the future. So thank you, everyone.